afternoon, good morning, good evening, esteemed colleagues, partners, and champions of adolescent health from around the world. My name is María Carmen Calle, and I am the president of the International Association for Adolescent Health. Today, we gather for this webinar on a call to action, the second Lancet Commission on Adolescent Health and Wellbeing, a transformative report published in 2025 that builds on the groundbreaking 2016 Commission to address today's escalating crisis. This session will review the original commission, highlights youth-led innovation in the second report, and outlines actionable recommendations amid pandemics, climate change, conflicts, digital shifts, and mental health. It emphasized the triple dividend of investing in 10 to 24-year-olds benefits now in adulthood and for future generations. As leaders in public health, we must translate these insights into policy and practice. And we are very, very honored to have these two extraordinary professionals in adolescence. First of all, I would like to introduce, I know that everybody knows her, but I would like to introduce Susan Sawyer, that holds the Health and Hanbury Chair of Adolescent Health at the University of Melbourne, and is director of the Center for Adolescent Health at the Royal Children's Hospital and Moore Children's Research Institute. She leads a WHO Collaborating Center for Adolescent Health. And Dr. Agustina Mensa-Kwao is a public health practitioner dedicated to advancing young mental health through research, advocacy, and service. She is currently a postdoctoral fellow in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health. Her work centers on youth engagement, mixed methods research, and implementation science, with more than a decade of experience across academia, government, and international organizations. Please. The floor is yours.
Okay, let me just hopefully pull up my slides. Yeah. Okay. Really lovely to have you all join, and it's incredibly exciting to be sharing the results of the second Lancet Commission on Adolescent Health, and I'm very grateful to Tina for joining me in doing so this evening. I thought it'd be useful to sort of frame why a second Lancet Commission. So as Carmen had signaled, I'm going to be doing sort of that introduction in terms of why a first commission, what we learned from that, and then I'll segue through to Tina, who's going to talk about youth participation, and then come back to me and I'll talk about sort of the approach and some of the major areas that we focused on. But I want to take you back to the Millennium Development Goals, because basically at that time there was remarkably little, if any, focus within the UN community on adolescent health. Yet, as we move towards the end of the MDGs to what became the Sustainable Development Goals, although they were not named as such at that time, each of the major UN agencies published really quite groundbreaking reports that really were building this momentum within the UN community in support of adolescent health. And that momentum was also supported by what I would call academic advocacy. So there had been an initial series in the Lancet in 2007 that Professor George Patton and myself had led. But I think it was really the 2012 series with 4 papers where the focus was much more in terms of a global perspective, recognising that 90% of young people live in low and middle income countries where, in effect, their health has been dramatically ignored. But I thought, George and I had thought we'd done a pretty good job in convening that in 2012. But the editor of the Lancet, Richard Horton, came back to us after that and said, look, job's not done. We've started publishing these things called commissions, and we want you to lead a commission on adolescent health and wellbeing. And I confess at that time that George and I looked at each other to say, what's a commission? And we then learnt that a commission is basically a big report. So this commission, our original commission, I think was about 55 pages with an accompanying paper. It's the whole of an edition of the Lancet with a series of accompanying editorials as well, with the intention of bringing a multidisciplinary group of people together to address what could be thought of as, if you like, as a wicket problem that a single discipline is unable to address. And so that combination of UN advocacy, academic support, and obviously this was just one of a number of reports taking place at the time, really then led not only to the SDGs, which admittedly didn't have that strong a focus on adolescence, but very much contributed to the global strategy becoming not just for women's and children's health, but for adolescents' health, the first time ever a global strategy had been inclusive of adolescents, with an accompanying global financing facility through the World Bank to be funding national investment. So this was an absolute high point in terms of adolescent health globally. And right at the time of that, was when this Lancet, our first Lancet Commission, landed. In that commission, we really shifted the thinking of adolescents, or intended to shift the thinking of adolescents from being this brief period of turmoil that we've all been through, that we all try to forget perhaps, to rather appreciating this profound period of human growth and development, in which the assets and capabilities that underpin future adult health and wellbeing, social relationships, parenting and employment are established. This health economics speak is the assets and capabilities, really signalling Amartya Sen, the Nobel Prize-winning economist, and recognising that these assets and capabilities don't just happen naturally, but happen when there is investment. And really that notion of adolescence as being potentially a foundation for future health across the life course. Perhaps the most memorable framing of the first Lancet Commission was the notion of investing in the triple dividend, and recognising that if we think of this butterfly diagram, as I call it, with the body of the butterfly being that horizontal line in yellow through to orange in adolescence, adulthood, and next generation, it's appreciating, firstly, and I'm a paediatrician and most of my paediatric colleagues see adolescence as the end of childhood, but really for us it was really trying to frame adolescence as the start of the next generation, that if we get those investments right in terms of actions that match needs, whether that's health issues needing health services, or community actions, particularly in terms of education, or structural actions in terms of, if you like, GDP in a country, responding to those priority needs with an appropriate set of actions reaps threefold benefits during adolescence, into adulthood, and then for the next generation. That notion of adolescence, and we defined, it wasn't new in the Lancet Commission, and it was certainly not new in this paper that I led a couple of years later, but we first really brought attention to this extended definition of the new adolescence of 10 to 24 in that second Lancet series. And while we referred to adolescence and young adulthood as the introduction to the first commission, we then shortened that throughout as adolescence. A really important feature was the work done on policy and legal frameworks, and really signalling that how we conceptualise and define adolescence influences very much the scope and focus of laws, and national laws being and national sort of policies and regulations being so important in terms of either promoting healthy development or indeed curtailing it. And so this notion within the first Lancet Commission of needing to balance through our policy and legal frameworks the care and protection, that top-down approach to young people as we would the same as for younger children, with that need to really be supporting young people's engagement and empowerment and participation and decision-making in their own lives, I think was really one of the major strengths that came out of that first commission. Another aspect that came out of the commission was thinking of three-country groupings. That notion of the poorest countries having the worst burden. We call these multi-burden countries with an excess burden from communicable diseases, HIV, maternal mortality, as sexual reproductive health and nutrition, and then injury excess as countries passage through and become wealthier and passage through the epidemiological transition. There's then an excess burden, particularly in males from accidents and injuries. And then as they continue to get wealthier, there is this green swathe underneath in relationship to complex chronic physical disorders and mental disorders. And so again, it was that notion of needing to match action to need according to where that excess disease burden was. And then another, it wasn't published in the Lancet report, but in the subsequent year, led by Peter Sheehan's group, also in Australia, who worked with us on the systematic reviews we'd done for the Commission, to really describe a benefit cost ratio of 10 for every dollar invested in adolescent health, and that was excluding the intergenerational benefits. I think this was really important because those investments were demonstrated to be greater on the left panel here in blue in low income countries, greater benefit cost ratio than lower middle income countries or upper middle income countries. And similarly, a greater return on that investment in countries that had higher adolescent mortality rates. So pretty important in terms of demonstrating the return on that investment. But basically 5 years after publishing the Commission in 2021, I think George and I sort of looked at each other and thought, where has this momentum gone? Because it really felt like things had become just a bit stuck. And there were a whole lot of new determinants of health that were really pretty worrying in terms of growing threats from commercial determinants of health in terms of food systems, for example, with growing rates of overweight and obesity, very rapidly increasing rates of urbanisation, slum dwelling with poverty and inequity, much greater frequency of conflict and war and population displacement, with the knowledge that that particularly affects adolescents, rapid digital transformations that were taking place, and then also the notion of, the triple planetary crisis in relationship to loss of biodiversity, climate change, and then air pollution. This sense that, and that was before COVID. So, there was the sense that we were needing to do something differently. So on that basis, the decision was made together with the Lancet to really embark upon a second Lancet Commission. And in the first week in December in 2021, George Patton, myself, and Alex Eze, a professor of adolescent health, originally from Nigeria and then from Kenya, where he'd led the African Population Health Research Centre and then had just returned to live in the States. The three of us were then co-chairs with Shakira Kunara next to Alex, who was the youth lead of 10 youth commissioners. So we pulled this group of 44 people together, including a quarter of them as youth commissioners, to have our first online meeting. It was the middle of lockdowns in COVID. And that was a very successful meeting. However, 2 weeks later, George, my husband, was diagnosed with stage 4 gastric cancer. And so he and I then stepped back from the leadership, handed over to Alex, and invited Sarah Baird and Russell Viner to, if you like, take over the reins. I was then pleased to join back after George died a year later, together with Pete Azzopardi. But it was a pretty rough early start, obviously, and a slightly delayed getting going. Having said that, all commissions take quite some time, but it was incredibly exciting then for us to be launching this at the World Health Assembly in May, launched by Tedros himself, and really trying to help build that momentum again. So I'm now going to hand over to Tina, who was one of our fabulous youth commissioners, who's going to tell us a little bit about that process of engagement and perhaps share a bit personally about what she learned through this experience as well. Thanks, Tina.
Okay, you can hear me, right?
Yeah.
Great. Thank you so much. And yes, as Susan mentioned, what made this commission especially powerful was the role of young people. The Second Lancet Commission on Adolescent Health and Wellbeing truly centered youth voices. Youth engagement was integrated across the commission's processes from conceptualization to publication. And as Susan mentioned, among the 44 experts, there were 10 youth commissioners younger than age 35 who were recruited to serve as youth commissioners. Each was connected to a relevant global or national network. And the youth commissioners were chosen following an in-depth expressive interest and interview process, which had the intention of identifying a diverse group of young people who could participate and travel at the global level. And so we were all chosen because we were working on changing our respective fields. This commission was intentional not only about including youth, but also about ensuring that young people led decision making. As youth commissioners, we co-led work streams alongside senior commissioners, shaping every stage of the process. For instance, I co-led a work stream with Dr. Pamela Collins, where we were looking at how cities can be developmentally responsive to youth mental health needs. And I'll talk about that a little bit later. One of the commissioners, youth commissioners, Shakira, she served on the commission's steering committee, which is like the leadership of the report. And importantly, our involvement was recognized and compensated. And through this experience, I had the firsthand experience of really understanding what meaningful youth engagement meant. It really meant deepening our collective understanding, which would lead to outcomes shaped by our lived experiences. As part of our role, we participated in two group meetings. One was in Nairobi, Kenya, and the other was in Cape Town, South Africa. And we came together as a commission to share progress across our work streams, discuss findings, and brainstorm next steps. During our meetings, youth commissioners led sessions on their focus areas and facilitated reflective discussions with other commissioners. So for me, that was all the work that we were doing around youth mental health. Another key part of youth engagement in the commission was the inclusion of peer reviewers, youth peer reviewers. And so during our meeting in Cape Town, these youth advocates were invited to review the draft of the report as part of the writing process. And they really ensured that the report reflected young people's priorities and perspectives. There was a group of 6. They reviewed for clarity, accessibility, and relevance to adolescents. And they pushed for plain language, stronger attention to equity, and better framing of issues like disability justice in youth mental health. All the youth reviewers were also compensated for their time. And together, we helped ensure the commission spoke with young people and not just about them. One key deliverable led by youth commissioners was the development of a meaningful youth engagement checklist, a practical tool designed to guide and assess youth engagement in research, policy, and advocacy. Oops, sorry about that. You can scan the QR code on the screen to view the checklist and the corresponding paper. The checklist outlines 3 key components: authorship and acknowledgement to ensure that young people are recognized for their contributions, whether that means being listed as authors or acknowledged appropriately; aims and methods, which encourages teams to clearly state why youth engagement is part of the work, describing who exactly was involved, and explaining how and to what extent young people participated. And finally, discussion and reflection, which focuses on what difference youth engagement actually made to the process, the research process, the advocacy process, whatever you're actually engaging young people in. And so how did youth input really shape that study, and what lessons were learned along the way? Youth advisory councils emerged as a mechanism for fostering meaningful youth engagement. helping shape priorities, guide programs, and drive advocacy. As part of the commission, we conducted a global survey of over 200 current and former Youth Advisory Council members to understand what meaningful youth engagement looked like. And there were three key actions for meaningful youth engagement that emerged. One, the integration of voices and expertise of youth advisory members into parent organizations. Two, structured and streamlined communication between youth advisory members and the parent organization. And finally, opportunities and resources for skill development of youth advisory members. So things like capacity building so they can be able to do this work. Another major contribution to the report was the Youth Solutions Lab. This effort was co-hosted by the Commission, UNICEF, and the Gov Lab. We brought together over 200 young people aged 16 to 20 across the world to co-create strategies for improving youth or adolescent mental health. And youth commissioners first helped to identify key areas of focus through a mind mapping exercise and voted on 5 key priority topics, which you can see here. Mental and emotional care was one of those priorities. The labs were held virtually, enabling young people from various regions to connect despite geographic differences. Each session was co-led by a youth commissioner who helped facilitate the discussions alongside senior commissioners and partners. Participants selected one priority area that resonated with them, and we worked collaboratively to identify barriers, design innovative strategies, and shape actionable recommendations grounded in their lived experiences. Participants emphasized the need to address stigma, strengthen access to care, and shift harmful social norms surrounding mental well-being. And what made the Youth Solutions Lab unique was that young people led the process, from shaping the structure to guiding the discussions, ensuring that youth voices directly informed the Commission's evidence base and final recommendations, which you can see in our full report. And as I briefly mentioned before, I co-led a workstream with Dr. Pamela Collins, where we were trying to understand what are the supports in cities for youth mental health. And so I wanted to highlight briefly some of our key findings. And as some of you know, mental health disorders are the leading cause of disease burden among people aged 10 to 24. And globally, 34% of individuals experience the onset of a mental health disorder by age 14, about 50% by age 18, and 62% before the age of 25. Poor adolescent mental health is strongly associated with recurring conditions in adulthood. Sorry about that. Adolescents are more likely than any other group to live in cities. And cities can help support the resilience, mental health, and well-being, as well as positive development among young people by implementing policies, programs across different sectors. And these efforts could be particularly effective if they address key aspects of adolescent development, such as developing a sense of identity, interdependence, self-determination, preparation for careers, connection to peers, and exploration of new opportunities. Schools can also play an important role as career and employment preparation, civic engagement, and creative activities. So for me, participating in this Lancet Commission was deeply meaningful professionally and personally. As a youth commissioner, I had the honor to work alongside brilliant, passionate young people from across the globe, each of us bringing our advocacy backgrounds, whether in disability rights, gender equity, climate justice, sexual and reproductive health, and mental health for me. The friendships and connections that I built with these young people, these young leaders, are friendships that I'm going to carry with me for the rest of my life beyond this commission. And also working alongside experts from diverse professional and cultural backgrounds really challenged me to think differently, to listen deeply, and to lead collaboratively. Last year, as Susan mentioned, we launched a report at the World Health Assembly in Geneva, and since then, we've been having launches across the globe from Sweden to Australia to China, and I helped lead our launch in Washington, D.C. here in the States. And you can see some pictures here. But these launches are just the beginning, and now comes the real work, translating the report's call to action into tangible change. This report is a roadmap that policymakers, researchers, youth advocates, and others can use to strengthen adolescent health and well-being at every level, local, national, global. Whether it's shaping policy, guiding investment, or reimagining youth engagement, This report has the power to drive real, tangible structural change. And as we look ahead, this commission makes one thing clear. Young people must continue to be at the center of this work. We must continue integrating youth voices in decision making, research, and advocacy. So change is not only for young people, but led with them. We want to engage, amplify, and protect the voices of adolescents in advocating for change and in making policies that affect change. Thank you, and I'll turn it right back to Susan. And I hope you learned a lot about how this unique experience for young people really helped lead this commission.
Thanks so much, Tina. Okay.
Adolescents are the future leaders of our world. Ensuring their health and well-being now and into the future is key to building a just society and a thriving planet. But are we doing enough? As we move towards and beyond the Sustainable Development Goals, we must prioritize adolescent health and well-being. The second Lancet Commission on Adolescent Health and Wellbeing has convened a global, multidisciplinary, and multi-generational group to tackle this critical issue. This generation is facing unprecedented challenges, from climate change to digital risks, conflict, and displacement. Today's adolescents are the first to experience lifelong climate change impacts. By 2100, 1.8 billion adolescents will live in a world projected to be 2.8 degrees Celsius warmer than pre-industrial times. The risks are real and rising. There has been progress, including reducing communicable diseases and improving education outcomes. But without increased investment, more young people will face declining health, with growing rates of obesity and mental ill health. Despite progress in some areas, our projections suggest that the SDG era will end with at least half of the world's adolescents, 1 billion, living in multi-burden countries where adolescents experience a complex and excess burden of disease. These will have lifetime and intergenerational impacts. Investing in adolescent health provides a triple dividend: benefits for young people now, for the adults they become, and for the next generation. Yet, global funding remains insufficient. Adolescents living in aid recipient low and middle income countries receive only 2.4% of total development assistance for health, despite making up 9.1% of the total burden of disease and representing a quarter of the population. Yet, there is hope. Education, economic growth, and digital innovation provide opportunities for even the most marginalized adolescents. School health initiatives and transformative public policies are paving the way for a healthier, fairer future. With the right investment and leadership and meaningful participation, young people can help reimagine a better world. For example, Bogota, a city in Colombia, introduced traffic calming measures based on traffic data analysis and road inspections to improve student safety commuting to school. Nepal's National Reproductive Health Strategy included a specific focus on adolescents. It aimed to increase access to health services, including counseling. Critical for success, the policy incorporated the perspectives of adolescents. The First Lady of Benin has championed ending female genital mutilation and cutting, joining First Ladies from Burkina Faso and Niger in 2017 to condemn this practice. The investments made in the generation of adolescents will determine our human and planetary futures, for good or for ill. The time to act is now. Together, we can make it happen.
Okay, so that's our 3-minute summary. What I might do now is just to take you through in a little bit more detail around the organizational structure of the report so that when you actually go and read it, and I warn you, I counted the number of pages last night, it's 77 pages, almost 21 pages more than the first report, and it's really dense. There's a lot of information in this. So in this report, it starts with two editorials, one from the Lancet editors, the second from WHO's lead. There is then an executive summary, and we know that many people don't necessarily get beyond the executive summary, but I would encourage you to do so. There are basically 5 sections in the report. So the first one here is really describing where progress has been made, where it hasn't been made, looking at really very detailed national level data and also projections through to 2050. And describing the policy landscape as well in terms of highlighting that, yep, there've been a whole lot of gains on one hand, but in other countries there have been stalling progress, and indeed in some parts of the world, and Carmen, I think we gave the example of Peru, there had been reversals of fortune in terms of policy landscape. Section 2 then was trying to understand what needs to occur to achieve greater investment. It was recognising that we've got mismatched and poorly prioritised funding. Work that Jeremy Schiffman led, a sociologist, was really using this language of the political economy of adolescent health and wellbeing, and really trying to explore why it is that adolescent health has not got the traction that other global health topics have achieved. And I must say that was pretty sobering reading. And then Sarah Baird led work on furthering the investment case for adolescents that we'll come back to in a tick. Section 3 was a pretty large section, which was really articulating this changing landscape and these shifting social determinants, really going into quite a bit of detail in a very diverse way. And it was really sort of signalling that in so many ways, young people are risking being socially excluded from their communities and are not being the recipients of the benefit of really belonging to their communities. This is the second African proverb. Tina will laugh because I really got into African proverbs at our 2 meetings. And maybe I didn't say that the reasons that Alex Etse was the co-lead, the reason that we had a number of African-based commissioners and that we held our 2 face-to-face meetings in Africa, one in Nairobi and one in Cape Town, as Tina said, was very much because if we look to the end of this century, that 1 in 2 of the world's adolescents will be growing up in the African continent. So Africa and Asia are really the population demographic powerhouses, if you like, of thinking about where investments are needed. And when we had actually submitted our report through the Lancet, and apparently our editor was saying that she was having to argue with her copy editors who said, we've never had proverbs in a Lancet paper before. So I felt very pleased to be able to include these. We had a lot of panels in the report trying to break up text, a lot of different diagrams really spanning a whole lot of things. I just thought I'd highlight we used exactly the same definition as in the first Lancet Commission, which was the same as in the second series on adolescent health, referring to 10 to 24 years and breaking that down in standard 5-year demographic age bands. And as Tina said, for the purposes of our youth commissioners, given that they needed to be independently able to travel and indeed to participate at fairly high-level global meetings, our definition for youth expanded up and included up to 35 years of age. We had panels very early on in terms of just stats, basically, describing how much the world is changing for young people. And I think the fact that an estimated, nearly 1 in 5 adolescents, 18%, are now living in conflict-affected areas, I personally found incredibly sobering. And, I really think that we were pushed in relationship to, really trying to think of the potential harms of population displacement from climate catastrophes, as well as also the potential benefits in terms of newer jobs that can be achieved through a focus on green and blue economies, a new word that I learned. I've put this panel in, which was about building national capacity, because I was particularly wanting to highlight the International Association for Adolescent Health. It was perhaps slightly with a vested interest, as I was president of IAAH at the time, or the immediate past president of IAAH at the time of this. But again, it was really trying to signal the importance of professional organisations like IAAH, and recognising in particular that in Africa currently there are only 2 national associations for adolescent health, one in Uganda and one in Nigeria, with a third in Ghana very soon to be formed. We had less attention to the 3 disease burdens and a greater focus on data at a national level, including how things had changed and also in terms of projections through to 2050. But in terms of those country groupings, what we did demonstrate was really the concern in the top panel, panel A. These are the number of countries. So in 2010, 71 countries were multi-burden countries, 52 were injury excess, and 81 were NCD predominant. And then you can see the shift in the Sankey plot as injury excess countries became NCD predominant, so with a healthier profile of adolescent health in 2016. Again, that shift in 2021. But of concern, if we look at panel B, which is looking at the adolescent population, as that video and graphic was sort of signalling, that basically the projection is that by 2030, half of the world's population, because of demographic shift, will be growing up in multi-burden countries experiencing the heaviest burden of health in any of these 3 types of countries. So really very concerning and signalling really where investments are needed. And in that sense, I really feel that this is perhaps the take-home statistic of the lack of appropriate investment in adolescent health in countries that are the recipients of, if you like, what's called developmental assistance or foreign aid. These countries are where adolescents basically constitute 24% of the population. So you've got a quarter of the population who are young people. They constitute nearly 10% of the population disease burden, yet have this disproportionate lack of investment in their health and well-being, notwithstanding all of that potential benefit of the triple dividend. So, we are completely failing in terms of making an appropriate suite of investments. Now, the last 2 sections then, section 4 was providing a conceptual framework, and then a lot of detail in terms of describing case studies, signalling the sorts of examples. We were trying to really be hopeful and illustrative of what is happening, where changes are happening in different parts of the world. So we really traversed the world in relationship to examples of demonstrating the importance of subnational data. And we used the example of Kenya for this. As Tina's alluded to, a lot of discussion around what meaningful adolescent and youth engagement looks like. Again, focusing on the importance of legal and policy environments. Did quite a bit of work looking at the policy in the UK in relationship to teenage pregnancy and the significance of that high-level national political leadership, and then having an accountability framework around that. So really signalling again how in a number of these sub-Saharan African countries in West Africa, Burkina Faso and Benin, it was a group of first ladies, so married to presidents, one of whom was obstetrician gynecologist herself, who were really able to change the conversation and change the complete tone in these countries in West Africa. And then at the end, sort of really framing up a new set of indicators. Perhaps I didn't focus earlier on, we really framed mental health, obesity, violence, and Tina, help me, what was the fourth area that we focused on? There was a fourth area where in section 3 we were really bringing a lot of attention to in terms of signalling these particular areas of health that we felt perhaps had been a little bit neglected. Was it sexual and reproductive health? So this was a conceptual diagram where this is the top half, which is looking at determinants, and you can see a very Bronfenbrenner-like socio and ecological model with the individual in the middle and going out in our waves to the outside, with then this notion of a set of cross-country or cross-cutting country amplifiers in purple around the outside. And in terms of this notion of, again, matching action to need, the actions were really needing to be multi-sectoral. We played a whole lot with this diagram, trying to be more overt in terms of, how the health sector might focus more on the inner part of the individual, whereas the education sector, would be focusing obviously more in terms of school and community, in terms of what part of that circle it's really attending to. But it's really trying to recognise the importance of multi-sectoral actions. And then in the solid blue surrounding this semicircle, it's recognising that meaningful adolescent and youth engagement needs to be part of all of this, not just within the Department of Youth, for example, where it might typically reside. So then section 5 at the end was around recapitulating, in a sense, many of the principles that we had articulated in the first Lancet Commission. They really hadn't changed. But really then setting out a set of recommendations for the post-SDG era that were really framed around these 3 headings: creating enabling environments to transform adolescent health and wellbeing, amplifying actions within existing systems to address adolescent health and wellbeing, and we particularly focused on the importance of the education sector, and then developing innovative approaches to address complex and emerging threats that it's meant to be in partnership with young people. And so these were the 13 actions here. I'm not going to go into these in detail, but you can see in the sense of that middle one of amplifying actions within existing systems, it's holding national education and health ministries jointly accountable for student health and wellbeing, ensuring universal access to adolescent responsive health care, equitable access to primary and secondary education, scaling up gender responsive actions. So multi-sectoral, multi-level, recognising the co-benefits that will come from investment in one of these actions. And this quote that Sarah Baird, as the lead, loves this particular quote, which is, I also think, a beautiful quote. And the point of young people was to become annoying about the truth they saw until it became evident to adults. Every generation must leave an impression, and it had to keep pressing into the group ahead of it until the impression was made permanent. And then a fresh generation would be born and look around, bewildered at their elders, and assert some newfangled idea that years from now would make perfect sense. So this was all of us commissioners when we were ourselves adolescent. Tina in the middle of the second bottom row hardly looks different to what she did as a teenager, but some of the rest of us, I'm afraid, look a fair bit different. But this was an important journey. We hope it's useful. The next steps, there has been funding from the Botner Foundation to invest in a countdown process over the next 3 years. So we will be publishing in the next few months a paper that's aiming to be, within virtually a year, if you like, of the first of the report itself, the second commission that was published in May. And then the plan is for another 2 publications following that. In addition, there is work to be having research priority setting exercises at a at a global level, and then working in 3 to 4 exemplar countries, really trying to help build the investment for the sorts of actions that are needing to be taken. We haven't yet identified those priority countries. That's really the task for the next few months. I'll stop sharing there, but hopefully we've left a little bit of time for questions. Thank you.
Thank you. There were two very important participations of Dr. Agustina and Dr. Susan. So let's have questions. Any question that you can make for our speakers, please?
I mean, I'll ask a question if it's okay.
Okay.
So we're really involved in our youth program. And what we're facing right now is really early suicide rates that in our country are up dramatically. And I'm working with our youngest youth ambassador who just turned 12, who've had 4 children in her district commit suicide from the age of 6 to 11. And we're doing our best to go in there and provide support and resources with our counselors and coaches and therapists and the things that we do, and just, expressing love. And I'm grateful we're working with principals and vice principals in the county right now to hopefully develop a strong enough program to take it to the state, and then hopefully to the, to DC. But are you finding the suicide rates globally with adolescents increasing in other countries as well, or is it not as bad as it is in the US?
Thanks for the question. Certainly I'm aware that in Japan, for example, that has long had a high suicide rate in adolescents, that they are experiencing the same phenomena that you describe, particularly affecting kids in primary schools. That having been engaged in some consultation around that and being an active listener. I mean, I know Japan, it's a country that I had lived in for a year when I was younger, but I was very much in listening mode, and they were describing the concerns about the extent that kids were left home alone with parents working very intensively, and also the extent of gaming and online gaming and bullying that was taking place through gaming networks. We've done a lot of work in Australia in relationship to social media and social media bans that you may be aware of, but without so much a focus on gaming. But in Japan, I know that was their particular concern. And I know that the group in Japan has been funded by their metropolitan government to put in place a suite of interventions to try and turn it around. They were really struggling to identify an appropriate evidence base, though, of the sorts of interventions that you might put in place. But again, this is where, really doing that work to be thinking of whole school approaches, that notion of health promoting schools. And we are certainly in Australia, for example, there is now a lot more work that's taking place in primary schools around students' mental health and wellbeing, not just historically where it's focused on secondary schools. Tina, did you have any other reflections that you could contribute?
So, from my understanding, the rise of suicide rates is not uniformly global. I know about decade, it's definitely increased in North America and some parts of Asia. In Europe, there has been a decrease in suicide among young people. So, certain countries in Europe might be a good case study to see, what's happening there and why. But we do know that and you probably know, ever since COVID-19, there's been a uptick in youth mental health crisis, and it would be alarming for the
There is a question here because there are many questions. There is a question here, please. Some global and local social communication strategy to disseminate the report recommendations. is needed. Is this issue considered by adolescent health champions?
Tina, did you want to talk about, any of the thoughts around plans for dissemination and developing some of the resources?
Yeah, so I can talk about our launch that we had here in the US briefly, because we definitely involved a lot of young people in our launch. And so, as I mentioned, like these launches about the report and disseminating the findings have been happening around the world. And in our launch that we had late fall in the US, we invited young people in the US across Maryland and DC to come really talk about their experiences. They read the report and like trying to help like disseminate it. And so one of the things that we're hearing from young people is the need to really like make the report more accessible for young people. As mentioned, it is a dense report. So trying to come up with like ways to visually represent the report, streamline the findings, infographics, things like that. Um, I and Shakira last year we had a web forum where there were young people across Africa who came to learn about the report and the findings. And so we're trying to figure out ways to get it to be more accessible for younger audiences. But there is a lot of interest in the findings because again, like this is about youth, young people were involved in the process, and we're trying our best to figure out ways to really get these findings into the hands of young people so they can use it in their countries, whether that's advocating locally on the ground in their countries. Susan, do you have anything else to add?
Yeah, just to say that within the new Botner grant, that part of that is going to be to try and be developing some materials that are more accessible. We fully appreciate that a 77-page Lancet report is one of the least accessible pieces of information for us as academics, let alone to young people. So yeah, watch this space.
Okay, here as an adolescent, how can I plug in to ensure we actualize the vision for prioritizing global adolescent health?
I'd be interested in your thoughts, Tina, but my response is that global is local. And so the question that I would be having here is how can we help connect you to people in your communities, in your countries, who you might be able to help work with, be informed by, share your knowledge with them. I must say that's one of the things that in terms of the International Association for Adolescent Health and María Carmen, you might want to speak about international, what are we calling it? International Youth, not Youth Day. I've had a mental blank. María Carmen, tell me what it's called.
The week.
International Adolescent Health
Global
Week.
Adolescent Health Week. Yeah.
Yes.
So if people are interested, is there an email that we can put in the chat that people could connect with? Because that International Adolescent Health Week is really focused on young people and them engaging with their local communities and with adolescents in their communities as well in a whole variety of ways. And so IAA sort of then connects young people and youth leaders to, for example, adolescent physicians in the area or other community leaders. So I think if we can do that, that would be ideal.
We are going to share in the chat where you can be in this International Adolescent Health Week. So Ellie is going to share that.
Ellie shared how to apply to be a youth ambassador, which is what that's called within Global Adolescent Health Week. So go for it.
But I want to say some things. No, it's very important that youth must know how are things going on. But it's equally important that adults must know also, because this is an intergenerational approach. And if we don't have adults as us, the three of us are adults. If we don't have adults that are convinced that this global adolescent health is and well-being is very important, we're not talking of nothing. So that's the idea of this webinar, and that IAWH is working hard for this. We shared a video that we made for this instance. We are sharing the panels, we are sharing the recommendations, the keys, everything in LinkedIn and in Facebook, because we think that the persons that attend adolescents must read this document. It is like we say in Peru, like the Bible. No, there are some documents that you have to read if you are with adolescent health and well-being. So, and in suicide, there is something very important. We are not teaching our boys and girls to make some kind of introspection. That's a problem. They are not looking inside them. We are talking everything it's outside, not the networks, all the things, but they are not going inside. And it's very important to teach them that sometime in your life you have to think about you. What are you doing? What is your life? How are you going in that life? So that's what I wanted to tell you. And I think, is there any mentorship available to these youth ambassadors?
Yes.
Yes, yes.
Is I think I saw Ngozi was online. Ngozi, do you
Yes.
want to have a quick chat?
Ngozi, here is Ngozi. Can you share something?
Or Mira?
Hi everyone. Good evening. Thanks for having me. I'm actually in the middle of a holiday, but thank you so much, Susan and Maria, for talking about Adolescent Health Week. The dates are all online. It's the second week of October, and the call for youth ambassador is still on, but that will be closed in about 2 weeks from now. So we're very much encouraging everybody to spread the word through their networks to get young people involved. And yes, we do have mentorship for youth ambassadors through individuals who already work with young people. So thank you.
Right.
Well, thank you so much. I want to say thank you to our speakers. You were really marvelous. And I want to tell you that we must read the Lancet, the 77 pages, we must read them. So we are totally convinced that what we are doing is very important. I think that everybody that is here, thank you for all the participants of all our 9 regions. We're very happy. This will be in the YouTube if you want to share it. But first of all, we have to begin us. We have to read the document. So we are completely convinced that working hard for adolescent health and well-being is mandatory. We have to do that. We have to do that now with all the crisis, the global crisis that we are having. So it's very important for us to do that. Thank you, Susan. Thank you, Tina. Thank you, Ellie, for the support. Thank you, everybody, and see you soon. In 2 months, we are all with a second webinar. Thank you so much. Thank you.
Thanks.